Can you hear me? Can you hear me? Okay.
Yes,
Thank you very much. I think what we'll do is I'm going to start off with just discussing as briefly as possible variants of concern, okay, variants of this virus, SARS-CoV-2. And then we'll move on to Dr. Files' biomedical impact of the vaccine, okay? And then we'll be open to questions after that. So I can have the next slide, please. Next slide. Who commands the slides?
I do, but I seem to be frozen here.
Oh, okay.
Just one second. There we go.
Okay, so this slide here indicates what has happened in the by now the most famous variant that crisscrossed across the world in a very short period of time. And if you can look here on this slide here, it's time in various months, okay, versus a weekly running fraction of that particular virus that was being analyzed at various places. Unfortunately, the United States is very poorly done a very poor job in terms of analyzing variants by sequencing. Again, do I have to? Okay. So if we look here, this brown here recognizes the amount of original virus that was coming out of Wuhan, China, essentially at the start of the pandemic. And then probably around in February, early February, a mutation started occurring at the 614th amino acid. Aspartic acid changed from aspartic acid to a glycine at the 614th amino acid of this 1273 amino acid protein, S protein, or the now famous spike protein that is critical for the virus to infect human cells. And then you can see that as time went on, this mutation, which is now blue over here, sort of dominated the all the variants that, or viruses that could be pulled out of individuals in human cases, and quickly changed the entire landscape of a virus that originally had the aspartic acid to now a virus that has this glycine. And can we have the next slide? Ellen? Next slide. Ellen, can you hear me?
Emily, do you want somebody else to try to share the slides since it seems, okay, you might want to go into the background. All right, I will pull them up if you give me one moment. Sorry about that.
Okay, thank you. Can you hear me, Nicole? Okay, so this here this indicates. Oh,
sorry, I don't know what's going on with my computer at the moment.
Okay.
We will try this one more time.
Okay.
Okay, we'll try it again.
Okay, so this map here just indicates the world. Okay, prior to March 1, as you can see, most of the mutation, most of the virus was the original Wuhan virus. Okay, originally described and sequenced in China, and then there was this mutation very early on in February, as I said, that occurred in Europe, mainly in Europe, but actually also elsewhere. That was independent of the. So this mutation can arise independently of. Wherever the original virus showed up. And then it didn't take very long. This blue is the mutation, the glycine in that 614 amino acid. And it didn't take very long for basically this new virus to sort of like sweep through the globe. And as of now, it's basically everywhere. All the viruses that we currently have in our midst are this B lineage glycine 614 virus. Okay, next slide, please. So how did that happen? And the current theory is, of course, that the S protein is a trimer on the virus surface that has to engage the ACE2 receptor on a human cell. And this mutation here at this point here in the protein was allowed the virus to engage the human receptor ACE2 protein that's on the surface of the cells that the virus wants to get into. It engaged those receptors at a higher affinity, allowing for the virus to be more effective in entering the cell, and then also increasing the so-called viral titer. In other words, the number of viruses that would be produced by the cell or of a human being, actually, not per cell, but the entire load of viruses produced by the human that was infected with this virus was higher in amount. And I'd like to say that the Cairo EM picture, the EM pictures of the virus, the virion doesn't look any different, okay, than the original virus, and the Cairo EM electron microscopy of the protein itself doesn't really seem to be majorly different than the original virus, but this led to further biochemical studies. Could have the next slide. So what was happening here? The original virus here in blue has a trimer that is necessary of the S protein to interact with the ACE protein. And there were two conformations basically that were permitted with the original aspartic acid in the 614 region. Okay, and these two regions had a certain amount of ability to bind and enter through AC2 binding. But then look, the virus mutation allowed for further conformations to occur, and this very open conformation here in 20% of the time, but even almost 40% of the time, this open conformation allowed for a greater binding and a tighter binding to the AC2 protein found on the cells that the virus wants to get into. And so really, it was a matter of engaging AC2 and entering cells in human beings. We have the next slide, please. Okay, so now you've heard many different variants coming up, popping up all across the globe. And the very famous one out of England was this B117. Okay, and what was that? This is the genome. It's not a circular genome, but it's just here for ease of illustration. It's 30,000 little letters of RNA, and there are a large number of mutations in number of genes found in this virus, the UK variant, so to speak, or this B117. And there were a number of mutations over here. This area over here codes for the spike protein, and there are a number of mutations here, as shown here. Again, they all have the D614 mutation, but there were a number of mutations. This asparagine to tyrosine over here was critical, and there was another one for stability. This P681 to histidine, the proline to histidine mutation, were found to be critical for not only again, even further binding affinity with AC2, but also the stability of the virus, allowing for a greater amount of S protein to be produced within the infected cell. Okay, next slide. So we don't have to wait. We don't have to wait for all of these variants to show up and then have their impact on human beings, which is critical, of course, for the further study of what's happening in this pandemic. We have some laboratory investigations that can allow us to analyze can these variants, for example, produce higher virus in models that we have? And so, in fact, we can see here the original Wuhan virus versus the mutant virus, the D614 virus, can infect cells in culture. And then we can analyze, okay, how much virus is coming out of these cells in culture? And we have animal models. The Syrian hamster actually can be infected, and actually we can cage them close together, and they can, one infected animal can infect its nearby animals, and sort of like a model of passing the virus from one animal to the next. And then we can analyze what is coming out of these animals, and we can see that the mutant virus is much higher titer, and also infects many more cage enclosed hamsters than the original wild type. And the overall impact is that, okay, is there going to be can we test antibodies that we've generated from the vaccines against these variants of concern? And so we can isolate antibodies from people that have been infected and or people that have been vaccinated. And then we can see, can we neutralize or stop the virus by having the antibodies coat the virus and preventing infection and virus replication. And so that is ongoing at this time. In all of these variants of concern that are being isolated across the nation, we now seen a considerable number of variants isolated in the United States. Finally, we're finally sequencing more viruses than ever before. And now we have a variety of, they're called bird viruses. They have bird names like robin or pelican or and whatever, that we're being tested now to see, can they evade the vaccine or can they reinfect if we've been vaccinated, for example? All of these things can be studied in the laboratory, but I have to caution that all of these studies in the laboratory are only models or indicators. It's the final clinical results that are really truly going to determine whether the vaccination population or the previously infected individuals really do substantially block a new coming variant into their bodies. And there's no other escape from that. There's no model or there's no in vitro system that can compare with the actual real clinical results. And so these are a help, but we sometimes do have to wait for the clinical outcomes in order to further our understanding. Do we need a new or a different type of vaccine, for example, has to be determined probably by clinical outcomes research. So, so far, and I'll conclude, there's actually 3 points that I'd like to make. Virus transmission can quickly spread. A mutation in the S protein can quickly spread across the globe, okay, due to virus titers and or a titer binding to ACE protein. Viral pathogenesis increased or changed due to more, there's 2 points here I'd like to make about this that are probably, you may not have heard elsewhere in the news, or too many people aren't concerned about this, but virus variants impact on pathogenesis can depend on a greater number of human beings being infected. So we all have a genetic difference in our immune system, and the more humans that are infected, the pathogenic response from those infections can be generated and can be slightly different from one to the other. I had COVID in my house not too long ago. We had 3 individuals infected, and I had 3 different presentations of virus infection in my little household of individuals. So the more viruses that get into, the more people, the differences we'll see. Now, here's the other main point. Virus that has the ability to bind to ACE can infect different tissues then with greater ability. So here's a key point that is not being easily transcribed. We've studied virus in the heart, for example, in our laboratory, and we note that there are very low levels of AC2 in various tissues very, very small amounts of AC2 in various tissues. If the virus, though, has a higher ability to bind to AC2, then it can get into different tissues that the original virus is infecting our country and our people got into. And so now we're going to potentially see effects and pathogenesis in virus that normally the original Wuhan virus, for example, or even the D614 virus did not get into. And so we could see more non-lung, for example, effects by these virus variants. And so that's why it's very important to continue to analyze and sequence and follow clinical outcomes of virus in our community in order to see is it following a standard pattern of infection and vaccine interactions, or is there something new in different tissues that we need to be aware of and worried about? So I think I'll end there and let Dr. File take up the rest of the talk.
Well, thanks, Nicole, and thanks, Emily, for inviting me to participate in this again. I always learn a lot, and I think the more information we have, the better decisions we can make about this COVID-19. We're always learning essentially every day. So could I have the next slide, please? And I thought I'd just start out, quite honestly, with an update of a slide I showed at our last echo having to do with COVID-19 or SARS-CoV-2, and look at some of what we've learned since then. And of course, as far as the virology, I think the most important issue is what Angelo just expertly mentioned, and that is the issues of these variants, and we'll probably be discussing that more as well. Regarding transmission, I mean, what we're very well aware now is the concern of patients who have asymptomatic infection, but yet can transmit it. And many studies now show that about 40 to 50% of all the transmission is from these asymptomatic spreaders. And that's why it's extremely important for us to continue to use mitigation behavior, specifically wearing masks. As far as manifestations, Angelo alluded to this as well. I mean, if you recall, initially, we just thought of 3 symptoms associated with COVID-19. And those were fever, shortness of breath, and cough. But now we know that virtually anybody can have any symptom, any manifestation associated with this. It doesn't have to be respiratory at all. And so that makes it even more difficult to differentiate from other clinical conditions. And we're becoming more and more aware of these sort of called long-term effects. I mean, now we've been seeing patients here since March, and I've been seeing patients who, 6 months afterwards, after they resolve their acute illness, are still having some concerns or manifestations of illness. We're more aware of how we intervene with patients and about the pathophysiology, that early on, it's the virus that's causing the manifestations, and we want to direct our therapy towards antiviral medications, whereas later on in the illness, it has to do with the immune system or the inflammatory response associated with the immune system. So we're going to direct our interventions towards that. And then, of course, lastly, it's the control. So that's what we're going to focus on today, is the vaccine. So if I could have the next slide, I want to go over some of the information concerning where we are with vaccines. Now, if you look on top now, this is sort of an old information from last November, but at that time, there were almost 150 preclinical candidates that were under study, but I'm just going to focus on 5 of them right here. Of course, the Moderna and the Pfizer, they're already authorized to use. We've administered somewhere between 50 and 60 million doses, or at least patients in this country who've received at least the first dose. And then there's the AstraZeneca, the J&J, which are sort of towards the end of their phase 3 studies. And of course, J&J is planning on presenting their data to FDA next week, actually, for possibly an EUA. And then Novavax, which is a little bit further behind. But I want to point out, if you look at all of these, they're targeting the spike protein that Angelo mentioned. Of course, that's the part of the virus that attaches to that ACE2 receptor. So if we can interfere with that process, therefore develop antibodies that neutralize that effect, we can reduce the infection into our patients. The technology, however, of these 5 are different. I mean, as we've heard much about the Moderna and the Pfizer, that they're based on this mRNA technology, which is relatively new for mass vaccinations, although it's been evaluated at least over the last decade. But this new technology allowed these vaccines to be developed very quickly in a very appropriate fashion as far as their testing. I mean, these studies that were done, and this is very important because when you talk about vaccine hesitancy, one of the biggest concerns is, was there any cutting of corners that these vaccines were able to be developed so quickly? And the answer is no. I mean, the studies were done very, very appropriately using high standards of scientific criteria. And then, of course, the AstraZeneca and J&J, they're similar in that they're a vector vaccines. In other words, where the spike protein has been inserted into another virus. Both of these were adenoviruses. Both of them are non-replicating adenoviruses. The AstraZeneca is in a chimpanzee adenovirus, and then the J&J is a non-replicating human adenovirus. And then the Novavax is somewhat different, as shown there. All of these require 2 doses except for the J&J. So that's going to be a tremendous benefit there. There's a significant difference in the storage requirement as far as freezer versus ultra cold for Pfizer versus just regular refrigeration for the other 3. So that's going to be important from the standpoint of distributing the vaccines. Now the efficacy here is just amazing. If you look at the Moderna and the Pfizer, 95% efficacy. Now, what the endpoint for these studies was, does the vaccine prevent disease? Not necessarily infection, but does it prevent people from getting sick? And so that's the most important issue. And to have a vaccine that is 95% effective in doing that is remarkable. And so we need to take advantage of that. Now, if you see the others, the AstraZeneca, J&J, and the Novavax, you can see that it's somewhat less. But you have to remember that these studies now were being done in areas where these variants that Angelo just mentioned are present, whereas the Moderna and Pfizer were done before that. And so that is somewhat of a concern. But I mean, even to have a vaccine that's 66, 76% effective, that's still very good. And I'm just showing you that there is somewhat of a less efficacy at developing or reducing disease in patients who are infected with that South African variant, the so-called B1351 variant or lineage. And then the bottom row is very important as well, because you can see that at least in the clinical trials, as I interpret them, the benefit of preventing death is 100%. So, I mean, these vaccines are going to be very helpful in preventing serious disease and obviously death. And that's why we want to make sure that they're available to the most vulnerable. Next slide. Now, the next couple slides, by the way, these are taken from CDC website, so they're available if you just go to the CDC website, and I've got the source at the bottom of these slides anyway. Now, I want to focus primarily on the 2 mRNA because those are the ones that are being administered now in this country. Both of them, are 2 doses. The Pfizer is 21 days. The Moderna is 28 days after the first dose. However, most recently, as you look at the bottom part of the slide, CDC has provided guidance that we can go out to 42 days. And so now that allows us some leeway as far as when we give that second dose. Next slide. And some of these slides actually will address some of the questions that have come subsequently to when I presented these slides. I think we have to acknowledge, and this is important when we tell our recipients of the vaccine, that these vaccines are fairly reactogenic. That is, you can expect side effects. Almost everybody's going to get some pain at ejection site. Some will get fever, headache, muscle aches. But there has been no significant safety concerns associated with this. Some patients can get Anaphylaxis, it's very rare, but to my knowledge, there's been no deaths directly related to any of these vaccines that have been administered over 50 million Americans so far. And I want to point out in the clinical trials, the FDA did not even consider authorizing these vaccines until there was at least an 8-week period after the second dose administered to these vaccines. Why that's important is because almost all of the significant adverse events associated with any prior vaccines have been seen within 8 weeks of that vaccine. So the fact that they did not hurry up as far as providing the authorization until that safety threshold occurred was very important. Next slide. And this just shows, if you just look at the highlighted column here, you can see that, you know, pain 70%, fatigue 33% or whatever. But if you look at the third column, this is the second dose of the Pfizer vaccine. And this is the same thing with the Moderna as well, but I don't have it here because the CDC didn't have the data. This is actually data from last month, but you can see that the second dose versus the first dose, you tend to have somewhat higher side effects, but these are expected. They're transient. They go away in 1 to 2 days. And it's basically just showing how your own immune system is reacting to this. So that when patients complain about it, I just tell them, look, at that just means that you've got a good immune system and you're developing antibodies, etc. Next slide. And so one of the questions we always have is, well, if patients have had COVID-19, is it okay or safe to get the vaccine? The answer is yes. But why would you? Because you're going to have natural immunity. Well, it's interesting, at least in the phase 2 trials, patients who received the vaccine had higher levels of antibodies, neutralizing antibodies, than those that had natural infection. The thought is that if you've had natural infection, let's go ahead and boost your immune system with the vaccine. Now, certainly we want to wait until a patient who has resolved their acute clinical illness and they're out of the isolation phase before we would administer this vaccine. But in the clinical trials, it did show that patients that did have prior COVID-19, actually they were benefited as well because they were less likely to get subsequent disease from which would have been a secondary infection with SARS-CoV-2. Next slide. And I guess the biggest concern we've had, particularly amongst our healthcare providers, the majority of them are women actually, is this concern about the pregnancy. And of course, pregnancy was a contraindication in the clinical trials, but we do know that the studies show that pregnant women do have an increased risk of more severe disease and also of preterm birth. So there would be a reason to try to avoid that. And so the CDC in their guidance, that's this last bullet point of this slide, did say that if women who are planning to get pregnant or are childbearing or are pregnant, they, quote, may choose to be vaccinated. And I want to point out that both the American College of OBGYN and the American Academy of Pediatrics both support this. That they say that it's okay for pregnant women to be vaccinated. Next slide. And I'm just showing this because this is a summary of what's called the vSafe data. vSafe is a smartphone site to be able to follow patients. And any of you on the call who have received the vaccine, you will know that you received information how to sign up for this particular source. I think it's very helpful because now millions have already been followed by this smartphone site. And I just want to point out that the bottom row of this particular slide, you can see that, and again, this is over, what's about a month old, it's January 24. But at this time, 15,000 pregnant women were followed with this vSafe program, and there was no significant abnormalities at all found so far. Next slide. And so just some other considerations before we go into the dialogue. The question is, well, in the clinical trials, did they include patient populations that were highly vulnerable? And the answer is yes. I mean, there was a high proportion of patients who had comorbid conditions that we know are associated with complications and in the elderly. And they were very highly effective in these groups. We'll talk more about the effectiveness in the variants. Angelo has very expertly mentioned. We do know there is some reduced neutralization activity, and I already showed you some reduced clinical efficacy in some of the vaccines that actually included patients particularly from South Africa. Major question we get here is, if I get vaccinated, will I need to wear a mask after being vaccinated? And the answer still is yes, for several reasons. Number one, we don't know yet, although I suspect this will be shown and studies are underway to evaluate this, we don't know yet if the vaccines truly prevent infection. That is asymptomatic infection that I mentioned earlier, because we know those patients can still transmit. There is some sort of preliminary analysis data from both the Moderna study and the AstraZeneca study to suggest that yes, it does reduce asymptomatic infection and potentially transmission, but we need better data about that. Secondly, we know that not all patients who receive the vaccine will be protected. And so there's a certain percentage that we need to wear masks because of that. And then there's the concern of the variants. And then also we need to have a high percentage of the population immunized, which we don't have yet, maybe 15% at the most right now in the United States. And the thought is we probably need 75, 80% of the population adequately immunized before we get the so-called herd immunity, where we might be able to start reducing some of our mitigation practices. Next slide. Now, here's the first change of the CDC in their guidance concerning patients who received vaccine. And that is now they say that if you've been fully vaccinated, which means for the 2 mRNA vaccines, that's 2 weeks after the second dose, you're fully vaccinated with your immunity, and you're asymptomatic, and you've had exposure and a significant exposure to somebody with COVID-19, now you don't have to quarantine. And that's, of course, within 3 months of full immunization, because that aligns now with the advice associated with natural infection, because the CDC's advice for somebody who has had natural infection in the last 3 months is that if they've been exposed, they don't need to quarantine. So now here's a change in guidance because of the receiving of the vaccine. So the next question, natural question is, well, if I travel, particularly if I travel internationally and I've been totally vaccinated, do I still have to go through all these isolation processes? And the CDC hasn't changed that guidance yet. We're hopeful once we get more data about reducing asymptomatic infection that basically if you've been vaccinated that you can sort of get a card that would show that you're immune or whatever. Another question I often get is, do I need to stop my regular medications when I receive the vaccine? And the answer is no. There is a caveat here that if patients have received the monoclonal antibodies, which we now use to treat patients who have mild disease, to try to prevent them from going to severe disease and not having to come in the hospital, if they've received these monoclonal antibodies, then we're supposed to wait 90 days before they receive the vaccine. Now we do know, and that's that last sub-bullet point here, that some drugs or some interventions may reduce the immune response, and so it may reduce the titers that are associated with the immunization, but we still say to go ahead and get it. I mean, patients on high-dose steroids, cancer chemotherapy, etc. On the other hand, if patients are on a transient dose or a tapering dose of steroids, that patients with maybe exacerbation of COPD, for example, will say, well, let's wait till you're off of the steroids before you go ahead and get the vaccine. Next slide, Nicole or Emily or yeah, this is a common question we get. Should I take, because I've already mentioned these side effects, should I take ibuprofen or acetaminophen prior to reduce these side effects? And the answer is it's not recommended. There is some preliminary data that taking these agents may reduce the immune response, and there's no clear data that they significantly reduce these side effects at all. Most of these side effects don't occur right away. They usually occur 8 to 10 hours after. And so if you take the ibuprofen before, that's probably not going to be a benefit anyway. However, once you do develop these symptoms, it is okay to take antipyretics or ibuprofen and acetaminophen to ameliorate these types of symptoms. Now, if you're pregnant, you should use acetaminophen rather than an NSAID. Next slide. I think that's the last slide I have for, yeah, we'll be talking about promoting vaccines. But the only point I want to make from here is that, you know, when we give information to our potential recipients, I mean, we just have to be transparent. We have to address the concerns about the various groups. And those of us who are in the healthcare field, I mean, we need to be champions of any vaccine, actually, whether it's influenza vaccine or in this case, a COVID vaccine, because from my perspective, the way we're going to get out of this pandemic is to wear masks and take the vaccine. So with that, I think I'll stop my initial remarks.
Excellent. I know we have a lot of questions in the chat box, and I know that Dr. Welton also had some information to share. Dr. Welton, do you want to go now, or do you want to go to the questions?
Let's go ahead to the questions, and we'll see what's out there.
Okay. Now, I'm scrolling back up to my chat box. It looks like Pedro Ballister, you have a number of questions. Would you like to unmute and share some of your questions?
Yeah, any comments on the Russian vaccine?
I don't have very much to say, except that it has been found to be effective in certain situations, and several countries, in fact, I think have signed up to use it. So, but it's not going to enter. You know, it's certainly not going to enter in the current vaccines that we're using. The ones that Tom showed are the ones that will be using across Europe and the United States. I know in South Africa, they have saved their AstraZeneca, which is not effective, and they're going to be passing that off to other countries. But other than that, that's all I know. I don't know if anybody else has something to say.
Yeah, I think it's a vector vaccine, and the efficacy, as far as I know, because their study was published a couple of weeks ago in Lancet. Their efficacy was like in the 70%. Their vaccine efficacy was something like in the 70% range, but I don't think we'll be seeing it in this country.
Pedro, you had a couple other questions. I don't know if you want to ask those two before we go to the next person.
Yeah, how long would it take Pfizer or Moderna to change their mRNA sequence if there's a new mutation?
Yeah, they're already doing that. In fact, in preparation for potentially a booster shot that would be maybe, for example, the South African, their current formulation is not against the UK variant or the South African variant. And so they're already currently doing that. So that's the science behind that. It won't take very long. The difficulty then becomes, again, the safety and efficacy of what the change that they make. So the changes can be made very quickly. And the production can be scaled up very, very quickly. It is the follow-up of safety and efficacy that is the question, and I don't know how they would handle that. But you could make changes and have production started probably within a month.
Thank you, Diane Brown. You're the next person in the chat with the question. Would you like to unmute and share your question?
Sure. I was just wondering some things that have come up about if someone gets the infection between their doses of the vaccine, whether or not they should take that second dose on time, they should wait. I've seen where you should wait 90 days after infection to get any vaccine, but this would be in between. So I was just wondering if there was any advice on that.
Well, yeah, actually, the CDC has provided guidance on that as well. And again, it depends upon where they are, whether these patients are after their first dose in their acute illness. But once they're out of their acute illness, and remember, patients after natural infection, they stop being transmitting or shedding viable virus 10 days after their onset of illness. So once they're out of that isolation phase, then they can go ahead and get their second dose. So in most cases, at least if, we've been administering the Moderna, so that's 28 days. In most cases, they've been able to go ahead and get their second dose as scheduled. But if they're still having some illness, we would wait up to at least 42 days.
Okay, thank you.
Jason Beers, you're the next question that I see.
He wants you to read it.
Fair enough, thank you. How many strands or mutations of COVID-19 are there now?
That's I don't know. Hundreds, I think, is the last estimate. Hundreds. So okay. So the problem is that we were very poor at isolating and sequencing our variants, and so the reason why they found it in England was that they have a tradition there of sequencing that goes way back, and so they actually were sequencing large numbers of clinical samples some time ago. And so that's how they discovered it first in England, that's just occurring here in the United States. So now with our ramp up, though, with our understanding that variants are very important, I suspect that we will have a huge catalog of variants and their impact on virus replication, of course, at first, but eventually clinical outcomes over time.
Yeah, and I might just add, and Angelo, and you're the virologist, but I mean, we know that these RNA viruses, respiratory viruses, they tend to mutate a lot. I mean, randomly, as they replicate, they're going to be mutating. There's probably thousands of variants that have no clinical consequence at all. It's just that we have to find these ones that are really important. And I agree. I mean, we haven't been sequencing them as much as we're supposed to, but I now know that the CDC is collecting strains from every state regularly to look at doing genomic sequencing. So I think we're going to have better data as we go forward.
Give you a scale of mutations, and so some comfort in knowing that our vaccination system should be pretty good. Is that if you think about influenza has perhaps influenza A probably has a 5 to 10-fold ability to mutate further than the coronavirus that we're currently dealing with. And HIV has 100-fold, if not even greater than 100-fold ability to mutate. And so you can see the impact that this great mutation rate has on vaccination and vaccine production. So that gives you a scale that going from coronaviruses, which can mutate very quickly, but not as quickly as influenza A virus, and certainly not as quickly as HIV, for example, HIV type 1.
Christine Frankenberry, would you like to unmute for your question?
Sure. I was just thinking, I know a lot of the rollout plans are kind of going with our elders first and going down. But I hadn't heard anything about whether or not experts feel that it'll be important or even safe or whatnot for our youth to end up getting vaccinated as well. So I was just curious if you heard anything about that.
Well, let me start out by addressing this. I mean, there was a study that was just recently published looking at the various demographics by age. I mean, what are the groups that are primarily doing the transmission or the source of the transmission? And it's basically those that are age 20 to 49, which makes sense. So these are the age groups that are most mobile, they're working, they're out in the community. They're also the ones probably more likely to congregate, et cetera. And so you could say, well, why shouldn't we immunize them if they're the source of the transmission? However, as I mentioned earlier in my slide, the benefit of the vaccine is to reduce disease. It's not necessarily to reduce transmission because we don't know about that yet, although I think it certainly will. And it's been very effective in reducing disease. So that's where we have to really look at, well, where is the greatest impact of disease? Well, it's in older, vulnerable people. I mean, if you look at the median deaths in Ohio anyway, the median age of deaths in Ohio due to COVID, it's 80. And so if you look at patients 65 and older, I mean, I don't know what the percentage, but I'm sure it's 75 to 80% of all the deaths are in that group. That's the people that we have to protect, and we should focus on first that we are doing. And so I think that's important. Now, as we expand the allotment of the vaccine, then we need to get everybody in the community, because as I said, that's the only time that we're going to be able to achieve a herd immunity. But if you look at the younger age group, even though they may be the ones that seem to be spreading it more, they fortunately don't have the significant impact of the disease. Although we have seen patients in their 20s without significant underlying conditions have very serious disease. It's not as at all common as with the older. Now, I'm not sure I'm directly addressing your question, Christine, but at least that was my response.
Yeah, I can say there's actually ongoing what are called step-down vaccination programs. In other words, they started with a certain age previously with 40,000, 43,000 in the couple Moderna and the Pfizer vaccination programs, and now they're stepping down. In other words, they're lowering the age, and then they're doing this in a two-step down process. And so I'm not, to be honest with you, I've forgotten what age group is currently being looked at in phase 1 and phase 2 studies. I think it's like 16-year-olds and up. And then they'll even actually go down below that. I think, like, for example, the next step would be like 12-year-old and around that age. And so it's very obvious that we want to eventually vaccinate these younger children. But in the meantime, we need the clinical data in order to make sure that it's safe and effective at preventing transmission, because Dr. File is correct. The original idea is that it's preventing disease and certainly death. We know that for scientific fact, but the ability to prevent transmission is still being carefully studied. Although I think that the data will, as Dr. File suggested, it will prevent transmission as well.
Thank you. That was very helpful.
Stephanie Keene, I have you next.
I was just wondering if there's data to show how many people are reinfected, and then if those people were reinfected, so let's say they tested positive for COVID twice, how does that affect their immunity?
Yeah, there are definite proven cases of original and primary infection followed up by a secondary infection, and those are fairly rare, although they're increasing in number. As to the real meat of your question, the data, I don't have the total numbers that have been cataloged. Clearly, you can have, but as an aside, you can have breakthrough infections even if you're vaccinated and or if you've been infected previously. That can be due to a variety of reasons. Okay, one is that the incoming virus may be a variation that we haven't discovered before that will just evade our previous immune system response to the original infection and or the vaccine. But you can also have, you were one of the 5% of the people where basically you didn't mount the antibody levels to prevent vaccine, and so you just got infected. And so, but maybe directly in your question, there is a waning of neutralizing protection, neutralizing antibody protection, and also a lack of T cell memory, because T cells may also be important, particularly preventing death, for example. We haven't fully analyzed this, but T cell response may be very, very important. And there seems to be a waning of memory to the infection, and also a waning of antibodies to the, and also T cell responses that occur with these viruses, coronaviruses, that over 8 months, 6 to 8 months, for example, there is definitely a waning. And so that's another variable that we very carefully have to study. What is the waning of the immune correlates, the correlates of protection? that the vaccine gives us, that we know we have a certain level of antibodies that are going to prevent infection. What is the waning of that protection is actually a very, very important question.
Yeah, let me just follow up. I mean, the CDC again gives us guidance, and it says that if you've had natural infection, they'll say that it's unlikely that you would be susceptible to another infection within 3 months. And that's this, guidance about, do we need to quarantine if you've had natural infection and you're out of that isolation phase? But let me just clarify, because this is sometimes very confusing to us, because we'll have a patient that comes into the hospital with acute COVID, and their test is positive using the PCR test, which, as you know, actually detects nucleic acid sequences. But people who have had COVID-19 can be shedding these nucleic acid sequences, not viable virus, but just some of these sequences for weeks to months. And so it's not uncommon for us to see patients who were in the hospital for active COVID-19 that go home. Now it's a month later, they come back in for some other reason. And if you test them with the PCR test, they're still going to be positive. That doesn't mean that they have a second infection or that they're persistently infected. It just means that they're shedding non-viable nucleic acid sequences. So that's something that has to be considered if you're doing these tests within a couple months of an active infection.
Finally, it's unclear. For example, this virus can go down in the gastrointestinal tract, and it's unclear. They've done some studies where they've been actually able to find virus in the gastrointestinal tract for quite some time. But whether that's infectious or whether we need to worry about that is at this point very unclear. But we're leaning towards that. We don't need, at least in this country, we don't need to worry about virus from the gastrointestinal tract, for example. That's probably not a viable route of transmission.
Thank you.
Lynn Hamrich.
Hey, good morning. So you guys have mentioned the effects of prednisone or other immune issues related to, or immune suppressants related to response to vaccine, delayed if someone's on a steroid taper, et cetera. I'm assuming other meds that modulate the immune system, like Otezla or other medications, may also have a similar decrease in efficacy to if patients taking them receive the vaccine.
Well, hi, Lynn. Yeah, that's true, although we don't know exactly the impact of that or the scope of that. I mean, because in the clinical trials, patients that had these were on these medications were excluded because they didn't want to reduce the efficacy. But studies are ongoing right now to look at that. I mean, the various immune modulators, various immunosuppressant agents, to what extent do they reduce the vaccine efficacy? So we'll know as those studies come on. But again, the guidance is by CDC that patients who are on these medicines should receive the vaccine to receive whatever benefit they can.
Monoclonal antibodies against SARS-CoV-2 have been shown to interfere with vaccine uptake. So that clearly, would be one of those things that any time that you're interacting with the immune system, this would be of some, it's theoretical. I'm mainly interested in theoretical concerns, but there are some practical concerns. But there's good advice from the CDC in what to do.
Yeah, and that the practical is important because we are administering the monoclonal antibodies to patients who are outpatients who have mild disease right now. And so we have to tell them, if you receive this monoclonal antibody, it's going to help you prevent progression of disease, prevent coming into the hospital. And we only give it really to patients who are at high risk of that occurring. But we also have to tell them that if you receive this monoclonal antibody, then you're not really eligible to receive the vaccine for 3 months because of that effect that you just mentioned, Angelo.
So Lynette Hirschberger asks, she says she knows someone with stage 3 kidney disease, and her nephrologist does not advise that she get the vaccine. Can you comment?
I apologize. I missed the question.
So she knows someone with stage 3 kidney disease, and the nephrologist working with this person does not advise her to get the vaccine.
Well, I'm not aware of why that would be any reason not to get the vaccine. I mean, stage 3 kidney disease is very common, particularly those of us who get older. But no, to me, that would not be an issue that, which I'm aware anyway, for which not to get the vaccine.
Yeah, I mean, there are very few theoretical concerns here. In fact, I would be very worried about these individuals. Anybody kidney, heart, for example, are things that we've certainly, like I said, we've done studies with heart in the virus in the heart, and we would want those people to be protected as much as possible. And you know, I would just say that this needs to be understood why there would be the suggestion. I mean, there may be some valid reasons on his part that he's read or understands. So, but I would just ask, what are the theoretical reasons for why you don't want me to be vaccinated? And then consult probably with Dr. File, for example, when given those reasons.
Yeah, because chronic kidney disease is one of the underlying conditions highly associated with severe complications.
So we have additional questions, but I think this question prompted some discussion that I think it would be a nice transition to Dr. Welton to talk about a little bit of the vaccine resistance and concerns around there, and then we can go back to the rest of the questions.
All right, thank you. Yeah, so this is a broad topic, a really interesting one about the people resistant to get vaccines. First, let me just give a little bit of a scope, and this far predates before any of us had ever heard of COVID, right? COVID-19, which was invented, right, a year and a half ago, because maybe Dr. DeLucia had heard of it, but none of the rest of us had ever heard of this, right? And now suddenly it's all that we're hearing about, and there's a lot of concerns out there. But before we had ever heard about that, 20 to 30% of young adults were having a fear of vaccinations, fear of needles. And about 1 in 6 American adults were refusing to get an influenza vaccine. Now, if you look at hospital employees, right, of all people, hospital employees you would think would be getting their vaccines, 27% of them, this is a large 35 research study meta-analysis, 27% of hospital employees were not getting their flu vaccine, largely because of a fear of vaccination. If you look at, so that was before COVID. If you look at since COVID, they've done a bunch of studies. And again, these are all early because again, it's only been around for a relative, or we've known about it widely for a little bit of time. But a large medical school, for example, they asked the medical students, how many of you would get a vaccine as soon as it's ready? Only 3/4 of them would. So a good 23% said, no, I would not get the vaccine if it was available. If you asked doctors and nurses, this was a study in Israel, how many of them would get the flu vaccine? Well, 90% of doctors would get the flu vaccine, but only 78% were going to get the COVID vaccine. If you talk to nurses in the same hospital, 69% would get the flu vaccine, but only 61% would get the COVID vaccine. So this is not just a few people. This is not due to stupidity or a mental illness or a blindness to the benefits of science. This is something that's very real and it's very widespread. And if you look in the population as a whole, it's at least that large. They did a study in France and found out that 1/4 of those folks said that they would refuse a vaccine if it was offered. One study looking at Jordan, Kuwait, and Saudi Arabia actually found that only about 30% would get the vaccine, that the rest would refuse it because of fears that they had. And if you look at this country, this is like a CNN poll back in January, end of January, 2/3 of Americans said that they would get a vaccine, but that means 1/3 would not. And this is after we've been hearing about COVID nonstop for a year. We've been hearing about the benefits of the vaccine for several months, and still 1/3 of the American public are saying they're not getting the vaccine. So just a couple so that's the reality. we do see the benefits of the vaccine. We want our folks to get vaccinated. So how do you help? How do you move them along? And I think, I can't remember who had it up on their slide, but one of their slides is to understand their particular reason. Because the reason that people are not getting the vaccine, there are a bunch and they're very individualized, but I'm gonna give you just several. One is ignorance, and ignorance in the true sense, lack of knowledge, right? They just don't know. They've heard about it. They've heard about a vaccine. They had a friend who got the vaccine and that person was really sick as a dog. And then they have another friend who had COVID and they were fine. You know, so the vaccine seems to make you sicker than the disease. Why am I going to get a vaccine? So sometimes it's just ignorance, and that's something that we can, you know, educate people. There's an awful lot of skepticism out there, though, and when that's present, I think we need to listen for it, acknowledge it, and then talk about it. The understanding of the virus. As has been pointed out, we're still learning a lot about this virus. This is something that, again, the population had not heard of, you know, 15 months ago. And now suddenly, you know, we're learning so much more, and it's now there are variations and hundreds and maybe thousands of variations. We thought it was one thing and now it's a lot. So there's a lot about the virus that people don't understand. That makes it frightening. There's a lot about the vaccine that people don't understand. And when you, and this had been brought up earlier, but when you ask people who are hesitant to get the vaccine, why are you not wanting the vaccine? 76% say it's safety and efficacy reasons. That, and I know Dr. DeLucia had brought this up, but this fear that, boy, this was fast tracked, right? We hadn't even heard of this thing a year and a half ago, and we have a vaccine for it. Well, HIV, we've been working on a vaccine for 30 years and we don't have one. You know, how did this get ramrodded through the system so that we suddenly have this vaccine and it's being released on an emergency use? Well, that means that they don't go through the normal steps. That means some corners are being cut somewhere. And that, again, that's the fear, that's the concern that we're having to address, to reassure people that no, the safety tests were done and they were done in the normal fashion, and the studies that say they're safe are just the same studies that are being done. It's not that we're cutting corners. It's not that we're, you know, ramrodding this through to get this vaccine out there. But there is skepticism about how the vaccine was created. It's also a novel, and even though I realize the technology has been around for an mRNA vaccine for a while, it's the first one I've ever, you know, been asked to receive. And how does this work? This works by doing something like DNA. That sounds like it's messing with who I am. I'm not sure about that. And so people, again, that's an ignorance issue, just lack of understanding. And that's something that we can educate. There's also skepticism about pharmaceutical companies, right? Just 2 years ago, they were evil. You know, they were out to destroy American society. We wouldn't let them on our university because those drug reps were so tricky and sneaky. And now we're getting everyone's getting a vaccine, and it looks like the vaccine may only last 3 months. So every 3 months for the rest of my life, I'm going to be paying these drug companies to give me a vaccine. That sounds a little suspicious. So there's concern about that. There's concern about government involvement in this. And so the line, I'm from the government and I'm here to help, is a punchline to a joke, right? Because people don't necessarily trust that the government has their best interests in mind. If you look at that study that said 2/3 of American public is willing to get the vaccine, there was a significant difference depending on the political persuasion of the person you're talking to. One of the political parties, 83% of them were going to get vaccinated. In the other political party, it was 49%. So not half, but close to. There's a big difference about how has the disease, has the vaccine been politicized? And so there is skepticism about that. And then experience, and I had mentioned this before. If we were in a big room, I'd ask you to raise your hand, but how many of you either personally or in a close family member have gotten the flu vaccine and then a month later you got sick as a dog because you got the flu? You know, we've all had that experience of vaccines that haven't seemed to help. And so you're asking me to take some, and there's lots of, you know, information, and in the public sphere, lots of talk about how uncomfortable these vaccines are and how painful these vaccines are, and it may not work anyway. And what are the benefits to me getting this vaccine? Does this mean I can take my mask off? No. Does this mean I can travel to foreign countries? No. Can I go to crowded theaters? No. Can I forget all about the social distancing? No. Am I going to get reinfected? Maybe. You know, so what are the benefits of this again? So Those are the kinds of questions. And so I do this in an exaggerated, flamboyant fashion, which is my style, but also just to point out that some of those are understandable. We may not agree, we may not see them in the same light, but they're understandable concerns. And when you run into that person and you start talking to them about getting the vaccine and they start having, oh, I'm not sure I'm getting that, it's important to take the time to find out what that hesitation is coming from. Is it coming from just a fear of needles, right? That's a good 20% of them. It's just, I don't like needles. Well, you know, it's a brief time, long-term benefit, you know, you deal with that. Sometimes it's going to be ignorance, and that's something we can educate. Sometimes it's going to be skepticism. And we just need to hear what that skepticism is, appreciate it, be empathic, be understanding where it's coming from. Again, especially in certain segments of society, there's a lot of distrust, and it feels, you know, and so understand that and sympathize. Yeah, I understand why you have distrust, but let me explain why I think this is a good idea for you in particular. Not for society in general, not for, you know, theoretical people, but for you as a person, this is why I think it's a good idea. And doing that kind of personal address is probably the best we have. I would love to hear, Dr. File, Dr. DeLucia, if you have other ideas from the folks you've been dealing with, but those were just some of my kind of initial thoughts I wanted to share.
Well, let me follow up with what Randy said, because a lot of what we've experienced is exactly what he said. Although, let me just say this about the flu. I mean, and you're exactly right, Randy. I mean, with influenza, I mean, the vaccine efficacy is only about 50%, 60% at best, quite honestly. And so I have all of the, because in our institution, in a lot of healthcare facilities they mandate that their employees receive the virus, or I mean the influenza vaccine, obviously to prevent transmission to the patients, to make sure it's safe for all patients. And I'll have a lot of my colleagues come up to me and say, well, I got the influenza vaccine. In fact, my wife even said this to me last year, that, you know, she received the influenza vaccine and then she did get influenza, you know, months later, like you mentioned. But I always tell her, well, you didn't die. I mean, we know that patients who develop disease for influenza after they've received the influenza vaccine, and it's been, you know, at least a couple of weeks after, so that they develop the antibodies, it significantly ameliorates the illness. And so even though it may not actually prevent disease, it significantly reduces the severity. So that's one point about influenza. And so, you know, we mandate that all our employees receive the influenza vaccine. We can't do that, obviously, with this vaccine because it's not approved. I mean, it's authorized through an EUA, emergency use authorization, but it's certainly not FDA approved yet. But we certainly are recommending it to all of our healthcare, you know, providers. And I will tell you that there's three big reasons why, at least that we've seen, for healthcare providers not getting the vaccine right now. Number one, because what you mentioned, Randy, there's this concern that it was too rapidly developed. And so we have to educate them that exactly what you said. The process through which these clinical trials were conducted were very high quality research, scientific protocols that followed all of the appropriate scientific criteria. And the only reason why it was able to be done so rapidly is because of the new technology, not because there was any corners cut, and also because the FDA put into their threshold that they would not even consider authorization until it's at least 2 months after the second dose of these vaccines, because of all of their experience in the past. That is where the significant adverse events had occurred. So they were very clear on that. And so I think that was number one. And so, like what you said, we have to explain that to them to give them a better understanding and appreciation that these were very well conducted trials, both for efficacy and safety. The second concern that we had from our healthcare providers, and remember, with healthcare providers, you're talking about mainly younger people, and the majority of our healthcare providers, particularly nurses, are women, right? And so the concern was, what about childbearing? What about pregnancy? And that's a very valid issue. And so a lot of our pregnant women or women who wanted to get pregnant wanted to wait. And that's okay, that's their decision. But we just wanted to make sure that they're aware. And then the fact that professional societies like the American College of OBGYN, the American Academy of Pediatrics actually recommend it, I mean, I think gives us a little bit more sort of validity to recommending it. But we have to appreciate that it should be a shared decision between the woman and her healthcare provider, and whether or not they decide which way or the other. We shouldn't have any, second thoughts on that. And then the third is what you mentioned as well, and that's the side effects. And so we have to be very, I think, transient, because we tell, everybody who's going to get the vaccine. And by the way, those of us who are older, the incidence of the side effects is significantly less than those that are younger. But for the younger age population, whatever that means, whether it's under 65 or whatever, they are more likely to have maybe some low-grade fever, more pain on injection site, feel fatigue, but it's only going to last for a day or two. We just have to, make sure that they're aware, and then that's part of the process of the response to the vaccine. And for those that say, I got so sick, I'm probably sicker than I would if I got COVID, well, I would have to say that now at least your immune system has responded, and you're going to be healthier, you're going to stop transmission, you're going to not get diseased from it. And so that is the benefit. But I think, and then the last point I want to make is that we deal with this all the time with vaccines. There's a group, like you said, maybe a quarter, a third don't want to get the vaccine. Well, half of those quarter or a third are in the anti-vaxxer group. We can't really deal with them. They will not listen to science or rational, discussion. But then there's half of those are what we call vaccine hesitants, or those that have hesitancy. Those are the people that if we educate, that we give them the information, and we're forthright and we're transparent with them, and we address their concerns, they're more likely to get the vaccine. So we just have to realize that those are the group of people that we should, focus on to improve the uptake of the vaccine. Those are the only initial comments I had, because I agree exactly what you said, Randy.
Excellent. Thank you both. We'll go back to questions. I have Isabel Rakowski next.
Yes, hello. So my question was, is there any research of, like, once you contract the virus, are you able to still get vaccinated while you're infected, or how does that work?
Actually, while you have the acute illness and while you're in the isolation phase, which means that you're in a phase where you're actually transmitted and are infected and shedding viable virus, you should not get the vaccine. So we know from studies that with natural infection, unless you're severely immunocompromised, you stop shedding active virus, and you can come out of quarantine 10 days after onset of illness. So what the guidance is that if you've had COVID-19, you've resolved your acute clinical illness, you don't have high fever, you're not clinically ill, although you may feel fatigued because that's very common after any viral infection, and it's more than 10 days after the onset of illness, then you can get the vaccine.
Thank you so much. Thank you so much.
I have Lisa Danmiller next.
Hello, wait a minute. I'm sorry, can you hear me?
Oh, yes, you can, absolutely. Go ahead.
Yes, I think some of the confusion on that was Dr. Fauci was suggesting 90 days after infection. So you may have heard of that. Some people may have heard that. That was basically an offhand suggestion that wasn't really based on real clear current studies, but there are some theoretical considerations, so that if you're you don't want to stress the body with immediately after infection with a vaccine, that the S protein is actually itself is a fairly stress protein that does cause stress on our cells. It's not completely harmless when we when we've been investigating it. So there is that consideration. And so I would definitely look at the CDC in order to note, I've been infected. This is the end of my 10 days or 14 days, but now 10 days is probably a better number. How soon can I get the vaccine? So I definitely would look at that recommendation, although I have to admit, Dr. Fauci mentioned 90 days.
Yeah, and actually just to follow up on that, part of that was, even now when we have a limitation of the allocation of the vaccines, the thought was if you've had natural infection, you are going to have a degree of immunity for a period of time. So if you are one of those who have had natural infection, let's save the vaccine for those people who are more vulnerable, who need the vaccine right now, for which during a time when there's a limitation of the allotment. So it's almost like an altruistic type of response. You know, I'm going to save it. I mean, I'm going to wait for, like you said, 90 days or 3 months or whatever, because that's the threshold that the CDC uses to suggest that after a natural infection, you probably still have enough immunity to be protected. And then I'm going to allow others who do not have any immunity because of natural infection to get the vaccine. So that's another reason why you might want to wait.
So a couple questions that I had. We have seen some young, healthy people with respiratory illnesses that test positive for COVID, 2 to 3 months later, come back again, respiratory illness. It's hard to differentiate whether it's COVID or not, but because it's that 2 to 3 month time period, if they test them, there's no real way of saying whether they have persistent nucleic acid detection or a new infection. So we just isolate again.
Well, our policy is if it's within that month and we don't isolate them because, you know, the thought is that if you're testing them, at least with a PCR test, what you're primarily detecting is non-viable nucleic acid sequences. If it's more than 3 months, we will definitely test them. And if it's positive, we isolate them.
So within 3 months, you do not isolate them again?
Well, there's going to be some changes depending on the specific patient situation. So I don't want to say definitely one way or the other. So it's going to be an individual decision based on the circumstances of the patient. But in general, particularly if you're just talking about somebody who's exposed, we wouldn't even consider testing if it was in 3 months of a patient having had documented active COVID disease.
What about, Tom, what about antibody levels, for example, testing for antibodies and their levels, amounts?
Well, the problem with that, we don't know what the correlation is with, because we're really not, well, even if you were able to detect the titer of antibody levels, we really don't know the correlation of whatever that titer is with protection. And so, and also the commercial antibody level tests that have come out, there's such a variability of the testing modalities that it's hard to interpret. I think probably the most important reason for us getting the antibody levels is when we see these patients that have this illness that might be consistent with this multiple inflammatory syndrome, to document that, because in that syndrome, the test for the virus itself or the PCR test may be negative. But it's important for us to know if they have antibodies to show that they had prior infection. Yeah. Now what we're seeing is an inflammatory response to that prior infection.
My second question was, I've gotten lots of questions from people, like if all of our office staff are vaccinated, can we start back to seeing ill face-to-face patients, or when will that occur? That's part of the question, but then again, we won't even know how long as healthcare professionals that we are immune or whether we'll require a booster. So I don't know if you have any comments on that.
Well, I mean, if you're using PPE, I mean, you should be able to feel safe in seeing patients face-to-face, you know, and because you don't know if the patients have received the vaccine. But I mean, and remember, if you receive the vaccine, that's going to protect disease. It does. we've talked about this a couple of times, and Angelo's mentioned this as well. We don't know specifically, although I think it will, and I think we both have said this, that it probably will prevent infection and therefore transmission. But certainly, if we've had the vaccine, it is going to help prevent us becoming sick with the virus. So that should give us some additional protection and confidence in being able to see patients face to face. But still, we have to wear the personal protective equipment. And as you know, Lisa, when we see patients, we're wearing high efficient, well-fit masks like what I've got here, like the N95s. Whereas when I'm going out, when I'm just walking to the hall or going out in the public, I'm wearing more of a regular mask, or even a cloth mask that I have as well. But I think you can't feel more confident seeing patients face to face, but you still need at this point in time to use the masks plus even the face shields.
I think PPE is more available now, but I think if everybody goes back to seeing all these acute patients face to face again, then you're going to have that PPE shortage. So I don't know, just questioning on, office practices in the future, because most of our ill patients we're doing telehealth if possible right now. So.
No, I agree. And so are we. But I think as some patients we just have to see based on what their condition is. But I mean, if it's a specific respiratory illness in which COVID is going to be in the differential, and now obviously anytime that any patient has a respiratory symptom, COVID has got to be the #1 potential cause. I mean, it's just amazing. We don't see any influenza, right? I mean, we've been doing probably 300 influenza tests because every patient that comes into our emergency room that therefore is a potential candidate for admission to the hospital and it has any respiratory symptom at all, it's a multiplex PCR test that not only includes COVID or SARS-CoV-2, but it also includes influenza. We've been doing about 300 a week. We have not seen, and we've had hundreds of, we've treated over 4,000 patients with COVID. We have not had any one patient admitted to this hospital with influenza A this year. Now, we've had a couple influenza B as outpatients, but we've not documented anybody. And we're testing, as I said, anybody who's being tested for COVID-19 for the last couple months anyway, is also being tested for influenza as well as other respiratory viruses as part of this multiplex PCR test. And we haven't seen any influenza. So, I agree that still a respiratory symptom right now still is COVID until proven otherwise.
Thank you.
So assuming that we answered Emily's question about working with people who are hesitant already, I'm going to go now to, it looks like Pedro had another question, and then after Pedro, we'll go to Carl.
Yeah, regarding the adenovirus vaccines, will they interfere with each other?
It's not clear. What do you mean? What interfere? Adenovirus vaccine will interfere with what other vaccine?
Well, okay, so there are some attenuated viruses, right? Vaccines. Okay, if somebody gets one vaccine with the attenuated virus, okay.
Yes, I understand. So, for example, like measles virus vaccine versus the COVID vaccine, is that?
Well, okay, so there are two vaccines now that are virus-based, right?
Oh, yes, I'm sorry. Okay, yes.
Okay, so if somebody gets one, will it affect if only the other one is available?
Okay, so good question. Okay, so here's what I can say about that. So, for example, why did they use chimpanzee adenovirus? Because many of us are already infected or have been infected by the standard vectors that are used. Okay, so adenovirus, human adenovirus type 5, for example, huge percentage of us are already infected. And so the idea is that let's use a virus that's not in the population, an adenovirus that's not in the population. It's very stable and very good vector, not in the population. And so that's what people have not previously encountered. And so therefore our immune system would, if we use the human type 5 adenovirus, for example, our immune system, which was previously exposed to wild type, would in fact prevent vaccine uptake and efficacy That's the chimpanzee adenovirus to carry the spike protein into human beings so that they could become, recognize the spike or S protein and then become immune from the wild type coronavirus. Okay, so there is an idea. So let me be sure. There is an idea that a previous adenovirus infection could prevent uptake of human adenovirus-based vaccine vectors. Okay, but it should not interfere with, like, if you were given the mRNA vaccine formulation, for example, there should not be any interference if you had the adenovirus-based vaccine, for example. Okay, does that help?
Yes, sort of. So the thing is, if, can one virus vaccine interfere with another in the same virus?
Sure. So there are some other ideas that we had to explore. So there are, when you get a virus infection, a previous virus infection and or a vaccine, the generation of antibodies could actually potentially be detrimental in some theoretical situations. And so it's called antibody dependent enhancement. So you could have antibodies that are not neutralizing the infection, the virus infection, that actually glob onto the virus, the incoming virus, and help carry it into the cell. So though there's that possibility. We had to worry about this, called ADE for short, antibody dependent enhancement. That was carefully looked at and has not been found to be the case with the current formulations of the various vaccines that Dr. Feild showed you. That there is no that theoretical concern or that issue is not happening in the COVID vaccine situation currently being done in throughout the world. Okay, so you do, and then there are other strange things that can happen. Okay, that have I'm not an immunologist, but I know that there are other strange immunological considerations that had to be taken into account when the vaccine was being formulated and then delivered and looked at in phase 1 and phase 2 studies that have been found in other situations. Dengue virus is a very famous virus where you had this antibody enhancement. And so you had to formulate the vaccine against 2 different serotypes, for example, to prevent that problem of actually giving a vaccine that could help a secondary infection with a different serotype of the virus. So that's been looked at very carefully and not been found so far to be of a concern in our present vaccination system.
Thank you, Angelo. So with 3 minutes left, we will go to Carl for our last question.
Hello. In following this and listening to these presentations already beginning of last year, one thing that seemed to strike me is that this COVID-19 has kind of forced us to really understand or come to light that there's a lot about our immune system, the human immune system, that we don't really know about. And there's a lot more human variation, both within individual, and I guess among populations than we didn't realize. And that has, of course, further complicated, but I guess it's a good thing, an upside that forces us to take a look at this. This can only be a benefit. So while everybody wants to focus on COVID being the bad guy in all this, I think there's an upside to it. But I also get the sense that, so I guess this is my question, is some of the things that I'm hearing about, like here, the waning of the T cells, possibility as remote as it is about reinfection. And it's amazing because, you could have 4 out of 4 billion and people will grab onto that as a significant number. Probably why people get excited about a 1 in 10 billion chance of winning the lottery. Not developing immunity to the vaccine, even though a small percentage, And then the other thing more recently, being able to transmit even when immune, being able to transmit even when you're asymptomatic, and of course the length of that for two weeks, and then lately I was hearing you can even go up to 3 weeks for justifying, of course, quarantine for up to 3 weeks, and then a couple of other things. And the impression that I kept getting was that this is like unique to just COVID-19, but I'm wondering if this hadn't also been true with other, like with the flu and other viruses, and we just didn't look at that because it's really, I think, if it is just true for the COVID, then it deserves all the fear around it. And if it has been also the case with other viruses that, so that's really is my question. Is this really has always been the case? Because I always remember growing up learning that, well, once you developed an immunity to, like once you got to a particular case of the flu, you had it for life. And then when you got older, like, I'm going to be 60 and, oh yeah, you might need a booster shot. And I only started hearing that, well, as I've gotten older, it's like, yeah, you might need a booster, as the body like forgets stuff, so any comment is this a lot of this stuff very, very unique to COVID, or just part and parcel for viruses, period?
Let me quickly, since we're running out of time, you've asked a very sort of vast question. Virology textbook is needed to answer that. But one thing right away, we learn more about the immune system because of HIV type 1 than previously, from when we started studying it. So you're right about that. We've learned a tremendous amount about the immune system previously, and we will gain even further understanding with this current pandemic. But as terms of viruses, the textbook understanding is that you have different pathogenic outcomes from virus. You have an acute infection, which the virus comes in, does its damage, replicates itself, and then leaves, and then is forever prevented from infecting you again. You also have chronic infections. Okay, so hepatitis B virus and hepatitis C virus get in, and they hang out despite an immune response that seems to be pretty determined to get rid of the virus. The virus can hang out in our bodies, a chronic infection or persistent. And then you have latent infections. Herpes virus comes in, it can infect various epithelial skin cells, and then goes up into the brain and hangs out there and hides out there, and then can be reactivated upon waning. And we have a lot of DNA viruses that I studied, JC virus, for example, in the kidney, or that goes latent, hides out, and then is reactivated because you have waning immunity. So we have all of these different patterns. They're called viral pathogenic patterns that have been known about for quite some time. In fact, the human coronaviruses were discovered in the 1960s. So we've known about coronavirus, at least, the ones that cause the common cold, since the 60s. And all of these patterns have been studied and understood. It's just that many of them don't have the profound effect on our economy, our certain age groups that this virus and has. Although we have lessons from 1918, right, that are sort of hidden away and are there, but apparently, remember, our technology was not the same, so we could not understand that infection as well as we're going to understand this one. And finally, let me conclude. This is preparing us. All of this work that you're doing and that we're currently being engaged in is help us again for the next one, because there is no way that we're not going to encounter another pandemic of this type of virus infection or something like it. It's guaranteed to happen in the future. And hopefully we will, as you suggested, we will be much better prepared to head that off and deal with it. In fact, even analyze and prevent it from even occurring, because we are far better concerned with the possibility of this happening again.
Thank you.
All right, we are at 8:34, so I'm going to thank everyone for joining us today. Thank you, Dr. DeLucia, Dr. Feil, and Dr. Welton for sharing information, for answering all of the questions. And thank you, everyone, for participating, for sharing your questions and comments with us. Take care of yourselves and one another, folks. Maybe we'll do this again.
All right, bye-bye.
Bye-bye.